The selection criteria for surgery at the current moment is age 18 to 65. I do want to highlight that my cutoff is not strict with 65. If there are people are functional, active, and they're older than 65, I'm open to evaluating and treating them. Of note, this is the selection criteria for surgery. There is no age cutoff for the medically supervised weight loss program. Continuing on the selection criteria for surgery, unsuccessful medical treatment, stable obesity for 5 years, comprehension of the procedure and compliance by the patient. Extremely important principle. Life is going to change after weight loss surgery. The stomach is no longer what it used to be, and hence if you put in the same amount of food, your body will let you know that it is not okay. And the way that it'll let you know is nausea, vomiting, abdominal pain. So really make sure that we have explained the procedure in detail, and the comprehension of what the life is going to change to be like is important. And for that purpose, we have a preoperative education class where my team members, including my dietitian, our patient advocate, and myself, we sit down and go into details about how your eating habits are going to change, consumption of alcohol, exercise, all of that. So when you go into the surgery, you have an informed, you are an informed patient and are ready to make that lifestyle change. No dependency on alcohol or drugs, including cigarettes. The surgical treatment, broadly we can classify the surgeries into restrictive and combined. Restrictive, as the name suggests, restricts the amount of food the stomach can hold. It's the gastric band, the sleeve gastrectomy. The combine is when you have a element of restriction as well as malabsorption, such as gastric bypass. So you're bypassing part of the gut, and hence that part of the gut that you're bypassing does not absorb the food that it used to before, and that is why they are a combined procedure, and that's where the malabsorption part comes in. Biliopancreatic diversion, duodenal switches are examples of combined procedures. The gastric bypass, this is the picture for that. What I like to do is go over the videos of the 3 procedures, and then we can compare them. So this is a cartoon of how the gastric bypass is done.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
And this is a cartoon video of how the gastric banding is done.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are placed through the trocars into the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The Realize band is introduced to the abdomen through a trocar. The Realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the Realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced to the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch restricts the amount of food you can eat before feeling full. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
And the last but not the least is a video of how the sleeve gastrectomy is performed.
The sleeve gastrectomy is a restrictive procedure which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
I'm hoping that these videos will have help explain the basic principles of how these procedures are done, and now we can do some comparison. The complications, I'm going to take a minute and talk about the complications here that are common to all three procedures is development of blood clots, also known as deep vein thrombosis or DVT. The risk factor for blood clots is obesity, surgery, immobility, and people who are undergoing surgery usually are not getting up and walking or running, or the activity is significantly reduced as it compared to when they were getting ready for surgery. And hence, as you can imagine, all my patients have these risk factors, whichever procedure they choose to do. So what we do to prevent deep venous thrombosis or blood clots in the legs is we give our patients blood thinning medication before we take them to the operating room. We time it to be at least an hour before, so by the time we make the incision, the blood thinning medication is in the system. Also, we continue our patients on blood thinning medications during the hospital stay, and they have to get up and walk. It's very important to be up and about the day of surgery and all the days following that, and that helps decreases the blood clots as well. With the procedures being done with small incisions laparoscopically, the pain post-operatively is minimal, and hence patients are able to get up and walk.